This conference will now be recorded.
Good morning, everyone. Today we'll discuss the practical about carcinoma of the breast. It is the most common non-skin malignancy in women. And coming to the incidence, it is nowadays most common malignancy in the women, and it is most common in the Western countries. Okay? And the incidence is increased, but the prevalence due to the mammographic screening and due to early diagnosis by mammographic screening and use of many chemotherapeutic drugs. Okay, all these factors has been increased in the prevalence. Okay, incidence and prevalence, and these factors led to the decrease in the number of deaths due to breast cancer. Okay, incidence is increased, but number of deaths due to the breast cancer is decreased due to early screening and use of many hormonal therapies. Okay. Coming to the risk factors of breast cancer, age. This incidence increases with age and it peaks at 75 to 80 years. Gender is most common in females and only 1% incidence in men. Age at menarche and menopause. Early menarche and late menopause have an increased risk. And age at first live birth, nulliparous women or late pregnancy leads to proliferation of cells with pre-neoplastic changes. First degree relatives with breast cancer, like mother, children, have an increased risk. Atypical hyperplasia in previous biopsies have an increased risk. Atypical hyperplasia have an increased risk, and proliferative breast changes without atypia have smaller risk for development of breast cancer. And race and ethnicity, white people have highest rates of breast cancer development, and postmenopausal hormone replacement therapy increases the risk of breast cancer. Okay, breast density. Those women with high breast density have less complete involution of lobules at the end of each menstrual cycle, and so they increase number of cells potentially susceptible to neoplastic transformation. So high breast density women have an increased risk of development of breast cancer. And exposure to radiation due to other cancer therapies or atomic bomb exposure or nuclear accidents have increased in the risk factor for development of breast cancer. And other risk factors are carcinoma of the contralateral breast or endometrium. 1% of women with breast cancer have increased propensity to develop in the contralateral breast cancer. Okay, and higher for women with germline mutations in BRCA1 and BRCA2. This is an important risk factor. Germline mutations in BRCA1 and BRCA2 have an increased risk of development of contralateral breast cancer or endometrial cancer. And geographic influence, as already discussed, US and Europe have a higher incidence, and diet alcohol consumption leads to higher estrogen levels and lower folate levels. Okay, alcohol consumption and intake of high fatty content in the food also leads to increased risk. Obesity. Postmenopausal obese women have an increased propensity for development due to increased synthesis of estrogens in the fat deposits. Okay. Breastfeeding. The longer women breastfed, the greater the reduction in risk of development. Okay. Other factors are environmental toxins like organochlorine pesticides are estrogenic, leading to development of breast cancer. And tobacco and cigarette smoke have an increased risk. Okay, these are the risk factors for development of breast cancer. And what are the major risks of breast cancer? In sporadic cases, due to hormonal exposure, and in hereditary cases, due to genetic factors. Okay, coming to the pathogenesis. What are the most common genes implicated in breast cancer? We have to know this. This is very important. BRCA1, BRCA2, P53, and CHIP2. BRCA1, BRCA2 are very important. BRCA1 is breast cancer 1 early onset, which is located on chromosome 17, and these functions are BRCA1 functions: transcription, DNA repair of double-stranded breaks, ubiquitination, and transcriptional regulation. And when is the defect? Germline point mutations or deletions of BRCA1 leads to hereditary breast and ovarian cancers. This is very important. Germline point mutations or deletions of BRCA1 gene leads to hereditary breast and ovarian cancers. BRCA2, that is breast cancer to early onset is located on chromosome 17, 13 and have functions like stability of the human genome and DNA double-strand break repair. And mutations in BRCA2 causes 20% hereditary breast cancer, ovarian cancer, and increased cancer risk in male carriers. Okay, this is important. BRCA2 is have an increased cancer risk in male carriers. Coming to P53, which is located on chromosome 17, the functions are cell cycle control, DNA replication, DNA repair, and apoptosis. And these mutations in P53 causes sporadic breast cancers and Lee-Froman syndrome. Okay. Coming to CHEK2, these functions are cell cycle checkpoint kinase recognition and repair of DNA damage, and activates BRCA1 and P53 by phosphorylation. Mutations in CHEK2 is rare, that is less than 5%, and associated with Lee-Froman variant, increases breast cancer risk after radiation exposure. Okay, these are the genetic mutations, genes. And other one is HER2/neu. Okay, HER2/neu, that is human epidermal growth factor receptor 2. It is a member of ERBB protein family. HER2 is a cell membrane surface bound receptor tyrosine kinase normally involved in signal transduction pathways which lead to cell growth and differentiation. Okay, approximately 30% of breast cancers have amplification of the HER2/neu gene or overexpression of its protein product. The protein product resulting from this gene overexpression causes breast cancer. Overexpression of this receptor in breast cancer have increased disease recurrence and it is associated with worst prognosis. Okay. Coming to estrogen receptor dependent tumors, that is ER dependent or independent. Approximately 75% of breast tumors are estrogen dependent, and tumors that do not rely on estrogen for growth are estrogen independent. See, this is an estrogen receptors. Estrogen binds to estrogen receptors to cause growth in ER positive cancer cell. Okay. This is the estrogen. This is estrogen receptor in ER breast cancer cell. If it is positive, ER positive means estrogen dependent. ER negative means estrogen independent. Okay. It is detected by immunohistological staining. What are the classification? What is the classification of breast carcinoma? More than 95% of breast malignancies are adenocarcinomas. Okay, breast carcinoma may be in situ or invasive. In situ is neoplastic cells limited within the ducts lobules by basement membrane, and invasive means penetrated through the basement membrane into the stroma. See, these are the normal ducts. This is the terminal duct lobular unit of a breast with higher density. This is fat. These are the terminal duct lobular units. Okay, this is the pectoralis muscle. Okay, this is a basic terminal unit. This is a duct and normally lined by ductal epithelial cells. Now, this is the normal cells. When there is ductal hyperplasia, there is slight proliferation of the ductal epithelial cells within the lumen. Atypical ductal hyperplasia means proliferation of the cells within the lumen, but with slight atypia. Ductal carcinoma in situ, more proliferation, and ductal carcinoma in situ with microinvasion is invasion into the stroma, but in a minor quantity, and invasive ductal carcinoma is infiltration into the stroma through the basement membrane in large quantity. This is the basic histology. Okay, see, as we can see, these are the normal breast tissues with normal ducts having simple single cell ductal epithelium, and in ductal carcinoma in situ we have proliferation, and this is the invasive carcinoma early stage and late stage. Okay, coming to the classification, this is very important. Classification of breast carcinoma: non-invasive or in situ carcinoma divided into two types: intraductal carcinoma, lobular carcinoma in situ. Invasive carcinoma is of many types: infiltrating or invasive duct carcinoma, not otherwise specified, NOS type. This is the most common. and infiltrative invasive lobular carcinoma, medullary carcinoma, colloid or mucinous carcinoma, papillary carcinoma, tubular carcinoma, adenoid cystic carcinoma, secretory carcinoma, inflammatory carcinoma, and carcinoma with metaplasia. Other one is Paget's disease of the nipple. Coming to carcinoma in situ, it is the malignant clonal population of cells limited to the ducts and lobules by the basement membrane. This is limited to the ducts and lobules. Okay? This is ductal carcinoma in situ. Most ductal carcinoma in situ are detected by calcifications on mammography. This is a mammography and showing calcifications in the breast tissue. This is the mammographic density periductal fibrosis surrounding by a DCIS. It is rarely palpable mass and there will be nipple discharge in some cases, and this is an incidental finding on biopsy for another lesion. Spreads through ducts and lobules to extensive lesions or to an entire sector of the breast may also be involved. DCIS involves lobules, acini distorted and unfolded. In the lobules, acini will be distorted and unfolded and appear as small ducts. And DCIS, 5 architectural subtypes of DCIS are solid form, Comedocarcinoma, papillary carcinoma, micropapillary carcinoma, and cribriform carcinoma. Cribriform carcinoma is the most common disease. Comedocarcinoma, solid sheets of, in comedocarcinoma, there will be solid sheets of pleomorphic cells with high-grade hyperchromatic nuclei and area of central necrosis. This is the necrotic area surrounding by sheets of pleomorphic cells. Okay, necrotic cell membranes calcify, leading to clusters of linear and branching microcalcifications on mammography. These necrotic on long-standing will be calcified, and these appear as microcalcifications in mammography. Periductal concentric fibrosis and chronic inflammation. This is the fibrosis and chronic inflammation, which is periductal in area. And extensive lesions are palpable as vague nodularity. And non-comedo DCIS, cribriform DCIS, monomorphic cell population, nuclear traits low to high. In cribriform, intraepithelial spaces evenly distributed and irregular in shape. In solid DCIS, completely fills the involved spaces. Okay. This is the cribriform DCIS. Okay. Cribriform pattern means holes. We can see holes in the ducts. Okay, this is solid. It completely fills the spaces. And papillary means papillary fronds, grows into spaces along fibrovascular pores. This is a papillae with central fibrovascular pore and lack myoepithelial cell layer. In papillary DCIS, they lack myoepithelial cell layer. Micropapillary DCIS, these are the micropapillary patterns, and bulbous, they present as bulbous protrusions without a fibrovascular pore. What is the difference between papillary and micropapillary? Papillary have a fibrovascular pore, they are very long. These are small bulbous projections without a fibrovascular pore and arranged in complex intraductal patterns. Calcifications associated with necrosis or form on intraluminal secretions. Okay. Next, coming to Paget's disease of nipple. This is rare manifestation of breast cancer and unilateral erythematous eruption or pruritus. Malignant cells or Pagetoid cells, Paget cells, extend from DCIS within ductal system via lactiferous sinus to nipple skin without crossing the basement membrane. From the DCIS, they proliferate into the nipple skin. Okay. Tumor cells disrupt tight squamous epithelial barrier to extracellular fibrous sweeps onto nipple surface, oozing scaly crust forms. These are Paget cells in the epidermis. Okay, there will be a scale crust formed on the skin surface. Okay, Paget cells are detected by nipple biopsy or cytological preparation of the exudate. It is a palpable mass in 50 to 60% of women. It can turn into invasive carcinoma. No palpable mass means DCIS. Fully differentiated, ER negative, HER2 or HER2 overexpression. This prognosis depends on features of underlying carcinoma. This is the Paget's disease. We can see scaly crust forming on the nipple, and these are the Pagetoid cells. Okay. DCIS with microinvasion, area of invasion through basement membrane involving the stroma more than 0.1 centimeter, and this microinvasion is associated with Comedocarcinoma and few microinvasive foci prognosis, and this has prognosis similar to DCIS. Okay. Lobular carcinoma in situ. This is an incidental biopsy finding. No calcifications or stromal reactions are seen. Bilateral in 20 to 40%. Young woman. This developed in young woman, and basic pathology is loss of expression of E-cadherin. E-cadherin is a transmembrane cell adhesion protein. So this is a E-cadherin protein. These are transmembrane cell adhesion protein. Between the cells, these are the adhesive proteins, E-cadherin. And these are E-cadherin is responsible for production of normal breast epithelial cells. Okay. When there is loss of expression of E-cadherin, there will be discohesive proliferation that leads to lobular carcinoma. Lobular carcinoma morphology: discohesive round cells with oval or round nuclei and small nucleoli. Absence of epithelium or mitotic activity. These are all. There will be discohesive round cells. Involved SNI is recognized by lobules with lobular architecture. Lobular architecture. And mucin positive signet-ring cells may also be seen. And this lobular carcinoma in situ is ER and PR positive. Okay. This lobular carcinoma in situ may change into invasive carcinoma. That is, incidence is 1% per year, and both breasts are increased and risk slightly higher in the ipsilateral breast. Okay. Ipsilateral breasts have an higher risk. Invasive carcinomas are lobular type. Treatment is bilateral prophylactic mastectomy, tomography, and close clinical follow-up from mammographic screening, which is the lobular carcinoma. Coming to the invasive carcinoma, which is the most important breast carcinoma, it clinically presents as palpable mass, sometimes axillary lymph metastasis or fixity to the cell wall or skin may be seen. Nipple retraction, we can see here in the picture, nipple retraction, and lymphatics involved. When the lymphatics are involved, block the local area of skin drainage, leading to lymph edema and skin thickening and teethering of the skin to the breast by TUMORS ligaments. This leads to faded orange appearance of the skin over the breast. And mammography, radiodense mass is seen in mammography. These are the clinical features. And invasive carcinoma is not otherwise specified. Is the most common type, invasive ductal carcinoma. Majority is in 70 to 80% NST type. No, not otherwise specified. Or no specific type. Gross appearance: most tumors are firm to hard. This is a grayish white, firm to hard, having irregular border. Less frequently well circumscribed border and the consistency. This is the gross appearance. When cut or scraped, characteristic grating sound. Grating sound is heard, and due to this grating sound is due to small central pinpoint foci or streaks of chalky white elastotic stroma and occasional small foci of calcification. Due to elastotic stroma or due to microcalcifications, this grating sound is heard when cut. Okay. And invasive carcinoma NST is divided into 3 patterns depending on the tubule formation, nuclei, microtubules, proliferation rate, and tumor necrosis. It is given grade 1 when tubule formation is prominent, when nuclei are small, round, monomorphic, and mitotic figures are there. It is given as grade 1. And when grade 2, when tubule formation is less, solid clusters or single infiltrating cells are more, and it has greater nuclear pleomorphism, and mitotic figures are present, means it is given as grade 2. Grade 3, when tubule formation is very less and raggedness or solid sheets of cells are seen. Here solid sheets are seen. Here in grade 1, prominent tubule formation is seen. When raggedness of solid sheets, grade 3, and nuclei here are enlarged and irregular. See, enlarged and irregular. irregular, and mitotic figures are numerous, and proliferation rate is very high. Tumor necrosis is present, means it is considered as grade. That is about invasive ductal carcinoma. Coming to invasive nuclear carcinoma, it is a palpable mass, mammographic density with irregular borders. Sometimes tumor infiltrates the tissue acutely, and little dysplasia is missing and not palpable. This mass is not palpable and no mammographic density. Okay, these are the differences between invasive ductal and invasive nuclear. And metastasis is difficult to detect. It is bilateral in 5 to 10% cases. What is the genetic abnormalities? Primarily loss of expression of CDH1, that is, which encodes E-cadherin due to mutations. Loss of E-cadherin also discussed. We also discussed in lobular carcinoma in situ. Okay, this is the same genetic abnormality, loss of E-cadherin. And how it appears: morphology, histological hierarchies, dispersive infiltrating tumor cells, often arranged in single file or in loose clusters or sheets. This is the Indian file appearance. See, we can see Indian file appearance. This Indian file appearance is the hallmark, histological hallmark of invasive lobular carcinoma. And here tubule formation is absent, and signatoring cells containing an intracytoplasmic mucin droplets are common, and desmoplastia minimal or absent in invasive lobular carcinoma. Okay, and well differentiated and moderately differentiated lobular carcinomas have diploid ER positive and HER2 overexpression is great. Poorly differentiated carcinomas, aneuploid, lack hormone receptors and may overexpress HER2. Treatment pattern of metastasis than other breast cancers: metastasis to peritoneum, retroperitoneum, leptomeninges, that is carcinoma meninges and meningitis, and the gastrointestinal tract, ovaries and uterus. All these are involved in invasive lobular carcinoma. Coming to medullary carcinoma, it is most common in and may closely mimic a benign lesion clinically and radiologically present as a rapidly growing mass. Mass is morphology well circumscribed. Well, this is a well circumscribed, soft, fleshy mass with little desmoplastia and more yielding on palpation and cutting. Okay. See, this is a radio dense lesion in the mammogram. And this medullary carcinoma, solid syncytium-like sheets of large cells with vesicular pleomorphic nuclei and prominent nucleoli in 75% of the tumor. And there will be frequent mitotic figures, moderate to marked lymphocytic infiltrate surrounding and within the tumor. This is very important point to distinguish medullary carcinoma. Moderate to marked lymphoplasmocytic cells will be there within the tumor. And this border in medullary carcinoma, there will be pushing border. That is, pushing border is non-infiltrative border. And this is poorly differentiated. And we can see high nuclear grade aneuploidy and hormone receptors negative. HER2 overexpression is also negative. Lymph node metastasis is infrequent in medullary carcinoma. Okay. This is due to overexpression of the adhesion molecules, that is E-HER2. Coming to mucinous carcinoma, mucinous or colloid carcinoma presents in older women. Median age is 71 and grows slowly for many years. Morphology: tumor soft or rubbery. Consistency and appearance of pale grey blue gelatin. Borders are pushing or circumscribed. In mucinous carcinoma, tumor cells are arranged in clusters and small islands within large legs of mucin. See, these are the large legs of mucin in which the tumor cells will be floating tumor cells in the background of large legs of mucin. This is a very characteristic hallmark of mucinous carcinoma. These mucinous carcinomas are diploid, well to moderately differentiated and ER positive. Lymph node metastasis is uncommon but can be seen. Overall prognosis is slightly better. Okay. Tubular carcinoma, small irregular mammographic densities and presence in late 40s. This is a very uncommon form, tubular carcinoma. Morphology: Well-formed tubules present in myoepithelial cell layer. Basement membrane is negative. Tumor cells in direct contact within the stroma. Apparent snouts are typical. Calcifications are present within the lumen. Within the lumen, calcifications are present. More than 95% of all tubular carcinomas are diploid, ER positive, HER2 negative. Okay, this is well differentiated and has an excellent prognosis. Coming to papillary and micropapillary carcinomas, these are very rare, 1% or fewer of all invasive cancers and more commonly seen in DCIS. Invasive papillary carcinoma is ER positive and has a favorable prognosis. Invasive micropapillary carcinoma is ER negative, HER2 positive, and lymph node metastasis is very common and prognosis is poor. Coming to inflammatory carcinoma, this is another type, inflammatory breast carcinoma, and the clinical features are reddened, swollen, and warm when touched, and PD orange appearance, and there will be an inverted nipple. Okay, tumors are swollen, erythematous breast is seen, caused by extensive invasion and obstruction of dermal lymphatics by the tumor cells, and underlying carcinoma is diffusely infiltrative and does not form a discrete palpable mass. This is a discrete presentation. Confusion with true inflammatory conditions delays the diagnosis. So it can be confused with mastitis. Okay, many patients metastasis at diagnosis or recur rapidly. And another one is metaplastic carcinoma. Metaplastic. This includes a variety of rare types of breast cancer. Okay, matrix producing carcinomas, squamous cell carcinomas, and carcinomas with a prominent spindle cell component. All these variants are seen in metaplastic carcinoma. See, we can see keratin pearl. This is squamous component or spindle cell component. Here we can see spindle cell component or matrix producing carcinomas. Okay, these are all the components in metaplastic carcinoma, and this is HER2 PR ER triple negative carcinoma, and lymph node metastasis is infrequent and prognosis is poor. What are the major prognostic factors? The strongest predictor of death. Okay, prognostic factors are very important in breast cancer. These indicate outcome in breast carcinoma and it varies widely. Prognosis determined by pathological examination of primary carcinoma and axillary lymph node metastasis. Staging, typing, and axillary lymph node metastasis is very important in the prognosis. And AJCC, American Joint Committee on Cancer Staging System, divides patients into 5 stages, 0 to 4, and it is correlated with survival. What are the major prognostic factors? Are invasive versus in situ carcinoma, distant metastasis, lymph node metastasis, tumor size, locally advanced disease, and inflammatory carcinoma. These are the major prognostic factors. Okay, minor are histological type and grade, gene expression profiling, lymphovascular invasion, DNA content, okay, ER/PR HER2 positivity, proliferative rate, and response to neoadjuvant therapy. These are all the prognostic factors. Okay. Types of stromal tumors: intralobular stroma or interlobular stroma. Intralobular stromal tumors are these are benign tumors, fibroadenoma and phyllodes tumor. Interlobular are lipomas, angiosarcomas, pseudoangiomatous, stromal hyperplasia, fibrous tumors, and myofibroblastoma. Okay. Okay, these are the fibroadenomas, phyllodes tumor. And normal male breast. Normal male breast consists of nipple and a rudimentary duct system ending in terminal ducts without lobule formation. Okay, here in normal breast, terminal buds are without lobules. Okay, that is the difference between female breast and male breast. In female breast, there will be terminal duct lobular unit. Here, lobular component is absent. Gynaecomastia is enlargement of male breast, and puberty or very aged due to puberty or very aged people or hyperestrogenism causes gynecomastia, and other causes are cirrhosis of liver, increased adrenal estrogens as androgenic functions of test, or drugs like alcohol, marijuana, heroin, ART, anabolic steroids used by athletes and bodybuilders, Klinefelter syndrome. These are all the causes of gynecomastia. It is due to imbalance between estrogens, which stimulate breast tissue, and androgens, which counteract these effects, unilateral or bilateral. Button-like subareolar enlargement is seen. Morphology In gynecomastia, increase in dense collagenous connective tissue, marked micropapillary epithelial hyperplasia of the duct lining, individual epithelial cells, fairly regular, columnar to cuboidal with regular nuclei. Lobule formation is very rare in gynecomastia. Here we have a specimen of breast cancer, which is invasive ductal carcinoma. Invasive ductal carcinoma, and this is identified as a breast. See, this is a nipple areolar skin with nipple areolar complex. So this is identified, and this is the huge, dense, fatty tissue, breast tissue. So this is identified as breast, and on cut section we have a grayish white infiltrating mass measuring about somewhat 4 to 5 centimeters, grayish white. We should describe this specimen. Okay, we have a simple mastectomy specimen measuring about 4 into 10 into 6 centimeters. On cut section, it shows a large irregular grayish yellow tumor mass measuring 8 centimeters extending to the lower margin of the breast, and it has infiltrating borders. Okay, infiltrating borders. Okay, large grayish white, and the size, color, okay, and it extending into the lower margin of the breast should be noted. This is a first, it should be identified as simple mastectomy specimen. Okay, diagnosis, carcinoma of the breast. This is the specimen of the breast cancer. Okay.